So much. I think for the interest of time, we're going to move on, but thank you very much, Aaron. So any additional questions, feel free to put them in the chat, and hopefully our speakers will get those to you. So we're going back to the University of Bristol for our final speaker in this session, which is Eva Li. There. Yeah, not at all. It is very warm, so feel free to get some water, and then we'll have a nice break after your talk. So yeah, thank you very much.
Thank you. Yeah, thanks everyone. I'll try to make my presentation converge before the tea break. So as you can see here, my presentation is to present you the results of a case study in rheumatoid arthritis, where we're looking at assessing different treatment sequences of Chinese population using a DS model. So I'll start by providing some background on the epidemiology, disease epidemiology, and the prior economic models used in HTA in this field. I'll then demonstrate a new model structure designed to better reflect the current clinical practice and the model parameters and the initial results. I also demonstrate how a DS model can be easily achieved in the R-PACT world and throughout. So what we have here is, as an autoimmune disease, rheumatoid arthritis can occur at any age, but has a peak age of onset between 50 to 70 years, and females are more likely to have it than the males. You can see this figure shows the recent global prevalence of this disease, and the darker the color, the higher the prevalence. As we can see, China has a relatively modest prevalence of 240 cases per 100,000 population. Currently, there's no cure for this disease, and the primary clinical target is trying to suppress the disease activity under threshold, primarily the remission, which is defined using different clinic indicators such as DAS28, and patients with remission is assumed to prevent the disease progression and have a overall better quality of life. So the first treatment is methotrexate, but it doesn't work for everyone. The biologics and JAK inhibitors offers alternative options for patients whose disease activity cannot be controlled by the conventional drugs, but still they work differently. So considering patients always cycle through different target drugs, assessing the entire treatment sequence is essential to inform the decision making. So next, I'll walk you through the two most iconic model structure used in HTA. The first is the Birmingham model, which is developed in the TreeEdge Pro. It is used to assess whether the two biologics, etanercept and infliximab, should be available in the routine use in NHS. It's a health state transition model defined by the HAQ score, which is a patient-reported measure of disease activity. And accordingly, the effect of disease activity on mortality is incorporated. And only two things sampled here: time on treatment and second, whether the early treatment discontinuation happens. And both cost and quality of life are estimated from the HAQ score. Later, the Sheffield model further developed it by introducing this individualized microsimulation because of the use of regression based on patient characteristics. This model can capture patient heterogeneity to a certain extent. So this model since then has been widely used and adapted in different healthcare settings. But still, there are some challenges needs to be addressed. It can be divided into two topics. The first relates to the choice of input parameters to represent the disease progression. For example, at the very beginning, the HAQ is used, but it's a patient-reported outcomes, which is not routinely collected in practice. Instead, the clinician-assessed disease activity, such as DAS28, informs the treatment decision, is assumed to better reflect the reality. Also, the models should account for the structure uncertainty in terms of statistical models to estimate the quality of life. And the second topic is pretty much about incorporating the emerging new clinical evidence, such as the treatment-specific long-term outcomes, and also the shift in the clinical practice that because of the adapted treatment regimes and also the individual patients individualized patient disease making. For example, for the dose adjustment strategies is often applied for patients who achieve sustained remission to prevent the overuse of these expensive health resources. So we're trying to address all of these issues in our model by introducing this treatment sequence simulation model. For now, for each treatment line, the discontinuation depends on three competing reasons: the in efficacy, toxicity, and sustained remission. So the DS model is better suited for this competing risk and their timing. And the model is based on the DAS28, consistent with the decision criteria in China, and we accommodate the 3 different utility algorithms. The one in the base case is based on the PTGA, the patient-reported components of DAS28. Another 2 based on the HAQ score and different measures of pain. If one specific utility algorithm is specified, the relevant variables will be modeled throughout in terms of the short-term treatment response and long-term disease progression, as well as the effect of disease activity on mortality. So we're trying to use this model structure to answer the clinical question regarding the cost effectiveness of treatment sequences initiated with the TNF inhibitors, a JAK inhibitor, tofacitinib, and another biologics, tocilizumab, the 3 recommended first-line target drugs in Chinese clinic guideline. And another new feature of this model is that the treatment sequences can be specified either at a drug level or drug class level. So if it's drug class level, then the result of each treatment sequence is averaged over according to the prescription weights of the treatment agents within the class. And an additional treatment switching criteria not showing in this figure is the abatansab can be used at the 3rd or 4th line if the prior treatment is discontinued because of the toxicity issue. Here is an example of the changes in disease activity score over time. So as you can see here, for each treatment line, there's an initial drop in the disease activity score to represent the treatment response. And over time, there is an annual change rate to reflect the natural disease progression. And by the end of each treatment line, the improvements in the disease activity score will be lost. So it was bounced back to the baseline value before it's switched to the next line. Based on these ideas, we have these input parameters to inform this model structure, including for those to define the target population. And for short-term outcomes, we have the ordered categorical ACR response rates from the network meta-analysis, which is used to estimate the changes in DAS28 for each response category. We'll also have the regression coefficients to estimate the trajectory over 6 months post-treatment for other disease activity score. And for long-term outcomes, we have the treatment-specific drug retention for each discontinuation reason, the time to reinitiation by stop reason, the long-term disease progression expressed in different disease activity score, and for the cost and the increased mortality hazard are stratified by the disease activity. And of course, we have the relevant input parameters to inform the alternative utility algorithms. Because the model developed in the Warden package is an environment itself, so it was running in the C++ by running the delay of the queue. We need to assign these input parameters within the model. Here is how we do this. So all the raw data are saved in the data frame, including the name of the parameters, the value, and its uncertainty, which can be converted to a list using the self-defined function prep list. And we use these data sets to assign the input parameters using the add item function from the Warden to specify the values in the base case analysis and also the relevant arguments needed to sample PSA values. Of course, if you have the values in the different scenario analysis, we can also specify it here. Here, it shows the event pathway using the first-line treatment as an example. So it aligns pretty much with the idea of short-term treatment response and long-term disease progression. But computationally, it's worth mentioning that the mortality and model horizontal are two additional compete events that need to be checked before the next event is activated. Also for the treatment discontinuation due to sustained remission, the dose adjustment is applied where the target drugs is withdrawn, but the methotrexate is continued to maintain the response. I'll get a better explanation at each step when we're looking at the model skeleton. So here, the main model skeleton is to define the event sequence using the add time to event function in the Warden package. So if the single drug indicator is set as false, it refers to the 3 treatment strategies I mentioned before. Otherwise, it corresponds to the number item of each treatment sequence with the single drug spread out. And here I define 9 events, the start and stop for each treatment line, and also the model accept. And for any input parameters that shared between events and haven't been specified before, it should be specified here using the other input arguments. And I only specify the initial start time as 0 because all the subsequent events will depend on the prior treatment response. And within each event, for any assignment of new input parameters and any changes occurs within that event, it should be activated using the add react event function. So for example, here at the start of the first line, I specify the treatments used for different arms and also allocates the treatment-specific parameters. A suggestion here is trying to keep consistency in naming the drugs throughout, so it's easier to use different lookup functions to allocate the corresponding parameters for the specific treatment. Here, we model the 6-month outcomes by using the NMA results. We sample the ACRE response category, which links to the changes in DAS28. And together with the baseline value, it determines the updated DAS score at 6 months post-treatment that informs the decision, treatment decision switching. So for non-responders, the treatment is switched immediately at 6 months. And for responders, we need to sample the time to treatment discontinuation additionally. Before that, we need to update any disease activity score that happens relevant to sampling the time to event. For example, here I shows the example of scenario analysis using the utility algorithm based on HAC, and the HAC score is relevant to associate with the increased hazard ratio, increased mortality hazard ratio. So here I sample the time to mortality both based on the Gombert's distribution, conditional on the current survived time point. And for the other 3 events, the remission, the inefficacy, and stop because of adverse events, I use the draw time to event function in the Warden. So it's a wrapper for sampling time to event by specifying the distribution and the parameterization used in the FlexServe rec package. And here we define the next event by selecting the earliest time, and we also save the patient status using different flags, and we activates the new event using the new events function by specifying the time point. Also, at the stop of each line, here we calculate all the cost and quality since the beginning of the treatments. Here I used a few self-defined functions to achieve this. For example, I have the set patients functions to list any treatments, including the co-treatment required for specific target drugs. And I have the drug use patterns to allocate the prescription frequency for the treatments, and also have the compute drug units to calculate the utilization of the drugs and any adjustments needs because of the patient's weight. And for the calculation of the quality of life, we encounter a situation that's the regression equations include the time-dependent covariance. So we can use the adjusted value function within the Warden, which can compute the adjusted average value over time. So also by the end of the stop event, we need to sample the time to treatment reinitiation. For the discontinuation because of remission, we sample the time to disease relapse. And for the other 2 discontinuation reason, the treatment reinitiation happens at the next outpatient visit, implemented as the next future point occurring at a 6-month interval. So based on these ideas, this is how the whole treatment sequences is sampled through, including the 4 target drugs and followed by a maintenance phase of conventional drugs. And also, by taking advantage of having the individualized patient data, we can kind of like replicate the treatment switching scenarios using the flags we saved before. So as you can see here from the first figure, there's still some heterogeneity between different treatments within the same drug. So here is the initial results from the base case. So compared to the TNF inhibitors, the treatment sequence initiated with the tocilizumab and tofacitinib are more expensive with lower quality. And also compared to the tofacitinib, the tocilizumab is not cost effective under the willingness to pay threshold of 200,000 Chinese yuan per quality. And here's the discussion. Based on my experience using this package, I feel like it's very flexible to model the treatment sequence, especially if you have different scenarios, and also to account for the structure uncertainties because of the different statistical models or the evidence sources. And the future works is to kind of like explore the variations in the results because between the different, by using the treatment sequence defined using single drug. And of course here, how to make this model run faster, the author already provides the options to run the simulation at multiple cores using the run simu parallel, but still I feel like when we need to run several scenario analysis, the time is still quite consuming. So don't know if there's any improvements could be done to improve the simulation time. Yeah, that's pretty much the whole presentation. And any question, let me know. Thank you.
Online ones, haven't we?
Oh yes, someone asked if you could share your user-defined functions online somewhere at all.
Yes, I will make this published in the GitHub.
That's great.
Do the one from HTA.
There's another one there. Sorry, I can only memorize one at a time. I can see the.
Yeah, so Eva, as promised, Javier, the developer of Warden, was online. So he's asking if there were any main points when you were implementing the model, and was there any feature that would have made your life easier? So how could Warden be improved based on your experience?
Yes, based on my experience, I feel like the actually for the calculation of the quality of life, the utility, they can just specify the EQ5D at each point, at each time point. But the thing is, I think the timing is calculated always forwards. So the timing can, if we want to, so if we can specify the timing by recorded from the prev time and current time, but the model itself is always calculated like forwards. So if there's any chance it can be like backward and forwards, there could be available options, then that be very flexible for the users.
HTA says get in contact with them.
Oh, okay.
Yeah. Good.
Oh yeah, there's one more question here. Here, I will.
Right, I have to be straight to the last one before the break.
Hi, thank you for the presentation. I just wanted to ask about the package that you've used, Warden, and whether you've considered any other of the discrete event simulation packages, and whether this one had any advantages that made you decide to use Warden instead.
I'm already so warm. This is fine.
Yeah, I haven't used the other package yet, but I know there's this can also do this work. But I think it's interesting to just compare different use, like implication of the different package, and definitely worth a try.
Thanks very much. Just say thank you so much again to Eva, and we'll have a break now until 22. Yeah, thanks so much.